Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Felden, and I organise Grand Rounds. And every year I have put out an appeal to ask for people to come and join us at Grand Rounds and speak and give an update on their specialist areas. We have some regulars that I can rely on every year to stick their hand up virtually and offer to give a talk. And Katie Hams is one of those people who has been a stalwart, I'll say, of Grand Rounds, and has spoken a number of times about a variety of things within her specialist area of haematology and blood transfusion. So I was delighted when she offered to give an update on blood transfusion, and she is going to speak, I think, about a general update on the service and the complications thereof, or what we can do about it, and what we can do better as clinicians to interact with the transfusion service to reduce the risk of complications, transfusion errors, and reactions, etc. So we have come on somewhat since 1666, transfusing blood from dog to dog, and this now is an issue. I think every area will be involved in blood transfusion at some point, and certainly needs some awareness of it. So I'm very grateful to Katie for coming back to Grand Rounds yet again to speak, and look forward to your update. Any questions, please put them in the chat, or wait till the end, stick your virtual hand up, and we can have some discussion. Katie, thanks very much.
Thanks, Tom. Hopefully you can hear me okay. So as Tom said, what we're going to talk about today is a bit of a general update about transfusion, and ultimately probably the theme of the talk is about transfusion safety. And as Tom said, everyone in all parts of patient care in Tayside is involved with transfusion at some point. So what I thought I would talk about, initially I'd thought about starting off with transfusion consent, but actually when I then had to think about it, in order to be able to consent patients for transfusion, you need to understand both about the potential complications of transfusion and about appropriate use of blood. So the talk has ended up being the other way round than it was when I started planning it.
Katie, can I just interrupt you very roughly on your microphone?
Oh, sorry.
Your mouth is a bit close and you're picking up your breath.
Okay. Hopefully that's a bit better.
That is somewhat better. Thank you very much.
Yeah, okay, good. So just to set the scene and remind you about blood transfusion in Tayside. So it's run by two separate laboratories, which are run by two separate organisations. So in Ninewells, we have the transfusion lab, which is run by the Scottish National Blood Transfusion Service. And then in Perth Royal Infirmary, we have the transfusion lab, which is under the auspices of NHS Tayside Blood Sciences. And although these are run by two separate organisations, we try as far as possible to work to similar policies and processes, so that particularly for staff who might work on both sites, there isn't a need to learn two separate ways of working. Ninewells lab supplies, obviously Ninewells, but also the Angus Community Hospitals, Stracathro, RVH, Roxburgh House. And then Perth serves Perth Royal Infirmary, Cornhill and the Perthshire Community Hospitals. And Ninewells also acts as the reference lab for PRI. So that means if there are samples which arrive in PRI that require complex testing, so things like patients with a mixture of red cell antibodies, for example, then blood will be cross-matched, sent through to Ninewells for testing, and then we will cross-match appropriate blood and send it back to Perth for transfusion. As it stands, if a patient moves site during an admission and requires transfusion, then a sample will be required by the receiving hospital's lab before blood can be issued. But we hope we might be able to change this in the sort of medium to longer term if we can link up our systems. And that'll make things a little bit more flexible for patients and streamline things for everyone. So watch this space. And I've put here just the numbers of units of the various components transfused in the last year, just to give you an idea of the sort of scale of transfusion. So we've got red cells, over 7,000 a year in Ninewells, then platelets, 700 units. About half of these will go to haematology patients, and then fresh frozen plasma at the bottom there. And you can see the smaller numbers, but still significant numbers of components transfused through in Perth as well. And there are various sort of levels of governance in place to try and ensure safe transfusion for all the patients in Tayside. So each transfusion lab has a hospital transfusion team, and that is made up of the consultant haematologist, so me for Ninewells and Duncan Gowans in Perth, the lab manager, potentially other biomedical scientists, quality manager, and the transfusion practitioner. And our transfusion practitioner in Tayside is Eleanor Knight, who I'm sure many of you will have met. She plays a vital role in transfusion education and really is that link person between the clinical areas and the laboratory, and really has a wealth of transfusion expertise. The hospital transfusion team is then represented at the hospital transfusion committee, and that committee meets quarterly and is chaired by Linda DeVille, one of the anaesthetists. And this is a kind of user group for blood using specialties, basically. So there are representatives from all of the main specialties who will attend that meeting. And it's this group which will ratify things like the NHS Tayside transfusion policies, for example. And then if we think about the sort of wider transfusion community in Scotland, there is the Scottish National Blood Transfusion Committee, and each of the hospital transfusion committee chairs from around the country joins together in that National Blood Transfusion Committee. And this is supported by the SNBTS transfusion team, and this is the team made up of transfusion practitioners, senior nurses who run a programme of work supporting safe and appropriate blood transfusion for patients in Scotland. And then the laboratory teams meet quarterly as part of the Haematology and Transfusion Scotland transfusion subgroup. So all of these organisations will contribute to policies and procedures relating to transfusion, and we have our own NHS Tayside policies which are available on StaffNet. So there is the transfusion of blood components policy, and there's massive hemorrhage policy. And then in the wider community, there are British Society for Haematology transfusion guidelines, which really form the sort of backbone of how we manage testing in the laboratory and clinical transfusion practice. So if we start then to think about, we've discussed all of these people and groups that are there to try and make sure transfusion is as safe as possible, and it is very safe, but it's not absolutely risk-free. And we get really useful data from this organisation called SHOT, which stands for Serious Hazards of Transfusion. And this is what's called a haemovigilance organisation. So they monitor for adverse events relating to all aspects of donation, so sort of blood transfusion, so from donation right through to blood transfusion itself to patients. And they've been collecting data since 1996 in the UK, and all hospitals which transfuse should voluntarily report adverse events relating to transfusion to SHOT. And SHOT then publish an annual report every summer, which reports the previous year's data. So the most recent one we have at the moment is the SHOT report relating to 2022's data, and we'll expect the 2023 report to be published at the beginning of July. And about 2 million blood components are transfused in the UK every year, about 200,000 of those in Scotland. And last year in the SHOT report, of those 2 million components transfused, we saw 35 deaths relating to transfusion, so not an insignificant number, and 144 patients suffering major morbidity. So I think this really highlights why we need to be careful with our use of blood. The graph that I've got on the bottom of the slide there shows other data from the SHOT report, which highlights that the type of reaction or adverse event and the number of these will vary depending on which component you're transfusing. So patients experience receiving a platelet transfusion are more likely to experience a reaction than patients receiving a red cell or other transfusion. So that's the sort of thing that you can then take into consideration when you're consenting a patient for a particular blood transfusion episode. And as well as the prevalence of transfusion reactions varying by component, the type of reactions that we see will also vary. So the most common, these are the top 4 types of reaction reported to SHOT. So we've got febrile, allergic and hypotensive reactions at the top. Those get grouped together in SHOT reporting. Then got transfusion-associated circulatory overload, which I'll talk a bit more about in a minute, hemolytic transfusion reactions, and then other pulmonary reactions. And the graph that we've got here, if I try and use the pointer, shows that depending what type of blood component you're getting, the type of reaction that might be anticipated varies as well. So on the left-hand side here, we've got the type of reactions seen in patients receiving a red cell transfusion. And so the most likely type of transfusion reaction if you're receiving a red cell transfusion is a febrile reaction. Whereas on the right-hand side here, we've got the type of reactions experienced by patients receiving platelet transfusions. And you can see that the blue bars are much larger here. And these are looking at anaphylactic or moderate allergic reactions. So if you're a patient receiving a platelet transfusion, you're much more likely to experience an allergic type reaction. And that's because there is a volume of plasma in a platelet component, and it's reactions to the proteins in the plasma, the residual plasma, that the patients tend to have allergic reactions to. Okay, so if we think then about probably the scariest type of transfusion error and therefore reaction in patient is ABO incompatible transfusion. So this is where patient of one blood group is transfused red cells or plasma of another group, leading to acute intravascular hemolysis. And that in turn leads to massive release of inflammatory cytokines, which leads to the patient becoming shocked, can lead to renal failure. And as you can see from the data here on the slide, in a number of cases, this can be fatal. So there were 6 instances of ABO incompatible transfusions reported to SHOT in the UK in 2022, and 2 of those patients died and 1 suffered major morbidity. So this is something that we absolutely want to avoid. And this is what all of the safety steps are in place to try and prevent. And of these 6 cases, 5 out of the 6 occurred primarily because of clinical error. So this is things like the final bedside check not being performed correctly and the wrong blood being connected up to the wrong patient. And the incidence of ABO incompatible transfusion is falling. So this is the very first year of SHOT data up until the most recent report. And you can see that the trend is downward, but it is, you know, we have not eradicated this completely, and it absolutely should be preventable in another event. So we need to do all that we can to try and prevent these ABO incompatible transfusions. So what can we do? Well, really, positive patient identification is key here. So identifying the patient at the time of blood sampling, labeling that sample at the bedside, so that there's no doubt that the blood in the tube is from the patient that you've just taken it from, and you've got the identification correct. And again, making sure that you're authorizing blood for the right patient on the transfusion record. And again, making sure that those pre-transfusion checks are completed properly at the patient's bedside to make sure that the right blood is hooked up to the right patient. You'll, I'm sure, be familiar with what's commonly known as the second sample policy. But what this really is a group check policy. So this is the process that we will not issue ABO specific blood for a patient unless a historic blood group from a previous time matches the blood group of the current sample. And so if a patient is admitted to hospital and we have never had a transfusion sample before, we will need 2 samples. And ideally, these should be taken at 2 separate venipuncture events, ideally by 2 separate staff. So they must be from 2 separate venipuncture events and ideally by 2 different members of staff. And this is to help reduce the chance that the blood in the tube is not from the patient whose details are written on the outside of the tube. And this, as I say, helps us to detect these wrong blood in tube events where the sample, you know, the result from the sample that we've just processed, the blood group doesn't match the historic result, and then we can identify that that blood was from a different patient. And this process works. So far this year, we have identified 2 wrong in blood in tube events because of this group check policy. So this was where samples arrived in the lab labeled with the patient's details, but the blood of the group in the tube did not match a historic group, and then further investigations and confirmatory samples confirm that indeed that sample was not from the patient that it was written on the tube. So we've had 2 in 2022. There were over 2,000 near miss events like this, wrong blood and tube events reported to SHOT. So this is common, and again, it's preventable. So please check your patient's ID with them before sampling, label it at the patient's bedside, and then make sure that those pre-transfusion checks are completed as well. And absolutely never take 2 transfusion samples at the same time and keep one to send later. It absolutely, you know, renders this group check policy pointless, and does away with that really important safety step that, as I say, we can see here locally is helping to identify this issue. Okay, rant about that over. Let's move on. So the second most common type of transfusion reaction reported to shot is TACO, so transfusion-associated circulatory overload. And this talk is actually quite timely because on the 4th of April, the MHRA issued this national patient safety alert to all hospitals in the UK, asking them to take action to reduce transfusion-associated circulatory overload. So the graph at the bottom of this slide shows the incidence of TACO reported to shot over the last several years, and you can see that in 2022 there were 160 cases of TACO reported. It contributed to 8 deaths and 25 cases of major morbidity. And over the 13-year period that's reported there have been 111 deaths, which accounts for almost 40% of all transfusion-related deaths reported to shot. So certainly an indication that TACO is a problem and something that we should be trying to address. And SHOT have this slightly complicated definition of what TACO is, which I'll give you a minute just to read through. And then I'll give you my interpretation of what that definition is. So I think what we're talking about here, this is patients who become acutely breathless during or within 12 hours of a transfusion, who have signs of hypoxia, and then clinical signs and imaging suggestive pulmonary edema, with other evidence potentially of fluid overload, and a rise in a pro-BNP test if that's available. And this is something which responds to diuretic, so offloading that extra fluid. The main differential diagnosis will be TRALI, so transfusion-related acute lung injury, but that is much less common, and it tends to occur in patients with other risk factors for acute lung injury, and it doesn't respond to diuretics. And I think TACO probably happens more than we in the transfusion service hear about here in 9 Wells, because we've only reported 1 case of TACO to shot since 2019. And that was in a neonate who are one of the sort of particularly vulnerable groups to TACO. So as I say, I think this is probably happening more than we in transfusion hear about. And that's maybe something that we can discuss a little bit at the end. So what should we be doing about this? Well, ideally, we want to prevent TACO by identifying those at risk pre-transfusion. And SHOT have, for a number of years, recommended that a TACO risk assessment is performed before transfusions. And again, this approach is endorsed by this recent patient safety alert. Now, fortunately, in Tayside, you are already prompted to do this. So the transfusion record, which you use to authorise blood for patients, on the front has this section about which is a TACO risk assessment. And I suppose the important thing is actually considering all of these factors for the patients, and if there is a risk identified, then thinking about what that means in terms of the patient's transfusion. So patients that will be at higher risk will be patients with cardiac or renal dysfunction, patients of low body weight, so to say neonates, but also children or elderly people with low body weight, patients with pre-existing fluid overload, and patients where they're given a high volume transfusion in relation to their body weight, and also patients with severe chronic anemia. So these patients who have also often become anemic over a very long period of time, may be compensating quite well for it, and these ones will be particularly at risk. So what do we need to do about it? One last thing, just when we're talking about the transfusion record, this is the sheet of paper which you use to authorise transfusions. This is still a paper document, and I know an awful lot of medical records in Tayside are now electronic, but this is still a paper document that needs to be completed, and the stickers confirming transfusion need to be stuck to the relevant bits within the patient's transfusion record, and then that should be filed in the patient's case notes so that there is traceability of that transfusion to meet with regulatory requirements. Okay, so back to preventing TACOs. So we do our risk assessment and we identify patients at risk. So what can we do? Well, always thinking about alternatives to transfusion where appropriate. So thinking about those chronically anemic patients where it's because of iron deficiency or B12 or folate deficiency, then using those alternatives rather than transfusion if possible. In Tayside, we have a single unit issue process from the transfusion lab, which means that single units of blood are issued on demand for patients. And this kind of supports a process of single unit transfusion where rather than blanketly providing patients with more than one unit of blood, you give a single unit and then reassess the patient to see whether that has had the desired effect. You can also consider weight-based dosing for children or adults of low body weight. And there's a suggested calculator there. There's also an app which can be used to do those calculations. And then thinking about whether giving some diuretic alongside the transfusion might be helpful, and keeping a really close eye on these high-risk patients, particularly when they're being transfused. Okay, so I thought it might be useful to have a bit of a reminder about what to do when there's a potential transfusion reaction. So if a patient who's being transfused, clinical condition changes, what should the ward team do about that? So essentially at the initial management for all transfusion reactions will be the same. So patient's condition changes. So if the patient begins to feel unwell or there's a change in the observations that are being done as part of the monitoring process, then the transfusion should be stopped. But not necessarily disconnected at that early stage. Then patient needs to be assessed urgently, so do their observations and make sure that the right bag of blood is connected up to the right patient, and then ask for the ward medical staff to review the patient. And what that review should do is to try and assess the severity of the reaction. And the severity of the reaction then gives clues as to what the underlying diagnosis might be. So we're hoping to classify the reaction into mild, moderate and severe. And this flowchart is from the British Society for Haematology guideline about management of transfusion reactions. And a version of this is available on StaffNet on the blood transfusion page. So if you have a patient suffering a reaction, you're able to refer to that. So if we have patients suffering from a mild reaction, so this would be a simple temperature rise to less than 39 degrees, without any other symptoms other than perhaps a mild rash indicating an allergic type reaction. If it's a mild reaction, should be documented in the medical notes, but it's reasonable to continue with the transfusion, closely monitor the patient, and if there's any further deterioration, then at that point stopping the transfusion and managing as for a moderate reaction. Severe reactions are where you've got a patient being transfused who's experiencing a life-threatening reaction. So might be anaphylaxis, might be sudden drop in blood pressure, so on. And in those instances, then blood transfusion definitely needs to be discontinued and contact the haematology registrar or me for advice about further management. Moderate reactions are really everything else. So significant temperature rises, other symptoms and signs, rigors, for example, other respiratory reactions would perhaps fall into that moderate category. And then it's important to think about whether what we're seeing fits with the patient's other clinical condition otherwise. So most patients in hospital receiving transfusion are not just there for transfusion. They will be in hospital because they've had an operation or in hospital because they're having treatment for something else. So have they been having fevers all day and then a fever coincides with transfusion? Or is this a patient who's been otherwise completely well and suddenly develops a fever and starts rigoring during a transfusion? So moderate and severe reactions, please do discuss with either the haematology registrar or me about the need for further investigation. But often in these cases, the right thing to do will be to stop the transfusion at that time, treat the patient symptomatically, and then consider further blood once they have improved. In terms of reporting, so all transfusion reactions should be documented in the patient's case record. Moderate and severe reactions, as I say, can discuss with the haematology registrar or me to advise about further investigations. And also these should be reported to the transfusion lab, either by the clinical team or by the haematologist. And we will then report any moderate or severe reactions to shot. And we also advise that a datex is raised for all transfusion reactions. Again, moderate and severe reactions should be noted on datex as well. Just a few words about other complications of transfusion. So there's a theoretical risk of transmission of bacteria, of viruses, of parasites, of prions. But thanks to a combination of donor selection processes, donation testing and various other measures, the risk of transmission of infection is very low indeed. The highest risk of transmission for the big three viruses is for hepatitis B, but an additional screening test for anti-hepatitis B core antibodies in blood donors was introduced in 2022 to try and reduce this risk further. And every year we recalculate the residual risk of hepatitis B, C and HIV from the blood supply, and it remains at less than 1 in 1 million donations tested. Another significant complication can be red cell alloimmunization. So this is where patients are exposed to foreign red cell antigens by transfusion, and that can invoke an immune response, leading to the formation of red cell antibodies. And we know that some patient groups are at higher risk, for example, patients with sickle cell disorder. And the consequences of that alloimmunization will vary depending on the patient and the clinical scenario, but for patients with childbearing potential, then that may be an issue. This antibody may cause hemolytic disease of the fetus and newborn in the future. Or for regularly transfused patients, then it may cause problems getting compatible blood for transfusion. So again, something to be aware of when you're thinking about transfusing patients. Okay. So having discussed the adverse events relating to transfusion, I think the next step in safe transfusion is ensuring that the patient really needs the proposed transfusion. So are you exposing them to these risks that we've just spoken about, and in a situation where they're actually unlikely to benefit from the transfusion? So the good news here is that in 9 wells, the rates of transfusion are falling and have fallen quite dramatically over the last several years. So on the top left, we've got red cell transfusions. So you can see in 2013-14, we were transfusing over 10,000 red cell components a year, and that has fallen to under 8,000 in the last year. And similarly, platelets have fallen from about over 800 down to just over 600. And that translates to a difference of over 3,000 fewer components being transfused. So that's a difference of about a reduction of about 50 components a day being transfused to about 20 components a day. So I think that's really a remarkable decrease, and it shows there's a really, a great deal of consideration going into appropriate use of blood already. And I don't have the breakdown of, which clinical areas have seen the biggest falls, but I think there's lots of work going on in Tayside which will contribute to this. So in obstetrics, there's a really good programme for the management of antenatal anemia, which will reduce transfusions to pregnant women and following postpartum hemorrhage and things. There's really active cell salvage programme in theatres. There's the preoperative anemia preoperative assessment, which includes assessment and management of anemia. So there's all of this work going on, as well as, just people being a bit more cautious, I think, and about transfusion, leading to this decrease that we're seeing. And all of these activities that I've spoken about form what we call patient blood management. And I think that's a kind of funny term. It doesn't necessarily explain itself terribly well. So I've put a couple of definitions here. The top one is a consensus definition from an international patient blood management group, and the bottom one comes from the WHO. But I think ultimately what patient blood management is asking us to do is think about transfusion like we would any other treatment. So considering the alternatives, only using blood when it is the most appropriate treatment for the patient, and then only using it at an appropriate dose for that patient. And if we think about the evidence for how we should use blood, it's now 25 years since the big first randomized controlled trial comparing so-called restrictive and liberal transfusion thresholds. So this was the first trial kind of questioning what hemoglobin should be used to trigger a transfusion, and that was the TRIC study, which was in ICU patients, and that demonstrated the safety of an approach of using a hemoglobin of 70 as that transfusion trigger. And these studies below have then gone on to look at the similar approach in different patient groups. So focus was in orthopedic patients, trigger was in GI bleeding patients, and then the TRICS-3 studies in cardiac surgery patients. So I think there is now a general acceptance that it is safe to use these restrictive transfusion triggers in the majority of stable, non-bleeding, not regularly transfused patients. And this was translated into NICE guidance in 2016, and this was then endorsed by the Scottish National Blood Transfusion Committee for adoption in Scotland as well. So this guideline suggests that for red cells for stable non-bleeding adults, we should use restrictive transfusion thresholds. So transfusing if the hemoglobin is less than 70, and then noting that patients with cardiac problems and recent acute coronary syndromes would benefit from using a threshold of 80 rather than 70. And it recommends that we transfuse 1 unit and then reassess and transfuse further units only if they are indicated, rather than going ahead and transfusing everybody with 2 units, which was probably what would have happened historically. I think one area where there probably is a bit of room for improvement here is transfusing or transfusion in iron deficiency. So the SMBTS transfusion team did a national audit a couple of years ago looking at exactly this question. So how many or what proportion of patients in Scotland with iron deficiency receive transfusion? And this used data from what's called the Scottish Transfusion Epidemiology Database, or STED. And what this database does is it combines clinical coding data about patient diagnoses with transfusion data, which comes from the blood bank computer systems. So we can identify patients which have a particular diagnosis and have also received a blood transfusion. So that data is obviously useful for all sorts of things, and it is available now in a dashboard called the Clinical Transfusion Dashboard. So if anybody is interested to have access with that and have a play about, you can email the address on the screen there to do that, to get access to that. Anyway, what this audit demonstrated that was a large proportion of patients in Scotland with iron deficiency do receive blood, and the audit standards that were used were derived from the British Society of Gastroenterology guideline for the management of iron deficiency. And this states that transfusion should be reserved for patients with severe symptomatic anemia and or cardiovascular compromise, and that the mainstay of treatment should be iron. So as I say, when we look at the Tayside data, which is what's shown on the screen here, we can see that probably between 30 and 40% of patients identified through this coding data as having iron deficiency have also received transfusion if they're an inpatient. So higher than what has been set as a national key performance indicator, and I think something that we could have a look at. So anyone interested in a bit of quality improvement in that area, then do get in touch. Okay, so we've had a bit of an update about potential adverse events and about when we should be using blood. So I think now it's probably helpful to think about how we use that in discussing transfusion with patients and thinking about how we would consent a patient for transfusion. And some of it is, exactly in the same way that you would discuss consent a patient for any treatment. So why would you want to give the transfusion? What would you consider as the benefits? What are the risks? And we've talked about those today. Any alternatives that might be available and why they may or may not be the right thing in this scenario. Consequences of the patient declining a transfusion. What receiving a transfusion would be like, and making sure that they have the opportunity to ask questions. And there are patient information leaflets about transfusion available. The QR code there will take you to it online, but there will also be paper copies available should you require them. And again, we've got UK guidance on consent, and this comes from the Expert Advisory Committee on the Safety of Blood, Tissues and Organs, who are called SABTO. And this was initially launched in 2020 and got kind of lost in the midst of COVID. So it was kind of relaunched a couple of years later. But this guidance states that informed, valid consent should be completed for all patients who will likely or definitely receive transfusion. And they suggest that, sometimes it can be hard to tell whether a patient may need a transfusion, so particularly, for example, for surgical patients. But if a patient's having a procedure where you're going to send a group and screen, so that they are covered, if you like, for transfusion, then it's probably sensible to consent them for blood transfusion as part of your consent process. If a patient receives a transfusion and they're not aware of it, so either in an emergency or during surgery, for example, then making sure that that patient knows that they received a transfusion is really important. Making sure that these shared decision-making discussions that have taken place are documented in the patient's clinical record, and certainly again on the National Transfusion Record, which is used in Tayside, there's a bit on the front about consent where the person authorising the transfusion will sign to say that they have obtained consent from the patient. It's really important as well that the SABTO recommends that it's documented if a transfusion has been administered in the hospital discharge summary. And again, I'm not sure how well that's done. I think that's another opportunity perhaps for a QI project. It's certainly, having a look at that in the first instance and then seeing, if there's improvement required. And the other thing during the consent process is informing the patient that they will no longer be able to donate blood. So as a variant CJD risk reduction measure, if you've been transfused in the UK since 1980, you're not able to be a blood donor. So again, informing the patient of that as part of the consent process is important. And after all that, there will be patients who decline transfusion, and they might decline transfusion for religious reasons. We're seeing increasing numbers of patients who decline transfusion because they do not want to receive a transfusion from a donor who's received a COVID vaccination. And the UK Blood Services have released a joint position statement on that, and we do not take details from our donors about whether or not they have received a COVID vaccine, nor can we facilitate directed donation, which has been a request made as well. So should patients decline transfusion, then it's really important that it's documented exactly what blood components or blood products the patient will and won't accept. And then having, a multidisciplinary approach to planning whatever care the patient is having. So if they have an operation planned, if they're pregnant, then making sure that patient blood management opportunities are maximised so that the patient doesn't come to harm while they're declining the transfusion. And there are documents about that will help you document exactly, say what blood components and so on that the patients would be willing to receive. That's all on the pre-assessment service StaffNet page. Okay, so finally, I think really the message is keep up the good work. We've seen this great big drop in the number of components transfused over the last 10 years. I'm not anticipating that if I gave another talk in 10 years' time that we would be down to zero, but I think, making sure that when we're considering transfusion, it's definitely indicated for the patient, and that we've considered the risks and the benefits is really important. Making sure that we consent patients for transfusion, making sure patients know if they have received a transfusion and making sure that that is all documented is important. Continuing with transfusing single units of blood, that happens a lot in 9 Wells already, but considering that as your sort of first option for stable, non-bleeding adults who are not regularly transfused. Monitoring patients closely for transfusion reactions, contacting the haematology registrar or me for advice should a patient's condition change during transfusion. And as I say, I think probably room for improvement on treating patients with iron deficiency with blood, and any other transfusion related QI projects, then please do get in touch. Be very happy to help, and we've got lots of data on lots of things. Thank you. I'll take any questions.
Thanks very much, Katie. That's fantastic. Really, really helpful. I think one of these things that I'm going to suspect most people's e-portfolio, if you're a trainee, or your SOR documentation, if you're a consultant, you need to have an update on transfusions. It's very helpful, as much as, and also how clinically important it is. And things do change, don't they? A number of things do change as we go. Why do you think that the numbers of transfusions have gone down by 4,000 since we were SHOs together?
I think probably the biggest reduction will probably be in surgical patients. If we looked, and I think we would be able to look more closely at this, and by putting this together, I then want to go and look more closely at it, but I think it's probably reduction in surgical blood use. I was chatting with one of the lab managers today, and he was saying in the old days, you know, people for a hip operation, you'd be cross-matching 6 units for a hip replacement. And these days that just doesn't happen. Your chance of needing a transfusion if you have your hip replaced is actually very low. So I think it's just big changes in, and things like doing laparoscopic surgery instead of open surgery, for example, just reduces the amount of blood loss. Using tranexamic acid at the time of surgery, again, to reduce blood loss and so on. So I think it's all of these kind of incremental gains, really. Making things safer.
It's been impactful, you know, from the only choice of things to now DOACs, reducing bleeding risk. There's a question in the do you count any death post-transfusion or only count issues like TACO, like if they've been having a major hemorrhage?
So in the shot data, death from major hemorrhage would be counted, but only if something related to the transfusion itself had contributed. So for example, if there was a delay in component provision and a patient died because of major hemorrhage and there was a delay in transfusion which contributed to that patient's death, then that would be something that we would report to SHOT. But we wouldn't report every death due to bleeding.
So if blood transfusion is part of what ends up to be a futile treatment for somebody, it's not the fault of the transfusion, is it? It's part of what we did to try to help it. It didn't work. Charlotte Proby says, what about an antibody that you can't identify when blood is sent for grouping?
Yeah, so it's a tricky one, and it doesn't happen tremendously often. I'll just curse us that this afternoon all sorts of weird and wonderful things will come in. But so we have, you know, a kind of repertoire of tests available in the laboratory here at Nine Wells. There is a reference laboratory in Glasgow, which is also an SMBTS lab, and they have some additional testing available, which can sometimes help get to the bottom of things. And if that doesn't help, then we would send samples to what's called the International Blood Group Reference Laboratory, which is in Bristol. And they do what it sounds like they do. So they have all sorts of extra testing that we don't have access to that can often help get to the bottom of things.
Any other questions from anybody in the audience? But yeah, Michelle has another question. Is there a clinic for patients who need regular iron, such as Ferinject, so that we can better avoid transfusion?
So I think it probably depends on which clinical service the patient is associated with, I think. So for example, in obstetrics, oral iron will be used first line, but if that is ineffective for one reason or another, then they will have facilities to provide women with parenteral iron there. Similarly, through the pre-assessment clinic, I think they will have access to intravenous iron through there. I'm not sure what the status is in medicine at the moment. Perhaps, Tom, you would be better placed to comment on that if there's patients needing intravenous iron.
Attendance here to see if there's a gastroenterologist who can answer the question of what they do, and there isn't one who's in the virtual room. But I do know that CIU does provide a service for injecting intravenous iron, and I'm pretty sure that's the process that's used is regular top-ups through CIU. We do see people who present fairly acutely into the acute medical unit with often really very, very profound anemia with numbers down below 50 and etc. In an iron deficiency pattern, and there's that, well, just give it some iron, it'll be okay. It's very difficult to stand your guns on that when someone is so anemic, and I think clinical judgment comes into that. Depends on the substrate. Okay, anyone else got any questions that they would like to throw at Katie before we move on? I think that's you off the hook then. Thanks very much, Katie. That's brilliant. Thank you.
Thank you.
Next week, Sheila Duffy, Chief Executive Officer of ASH Scotland, is going to come and talk about smoking in Scotland, the Tobacco-Free Scotland policy campaign that ASH Scotland has. I'm sure she'll mention the tobacco and vape bill that's just been voted on in Westminster this week and the controversy that that threw up. And a question I get asked as a chest physician a lot is, how bad is vaping for you? Is vaping bad for your lungs? And she's going to come and talk about the evidence base that around the damage that vaping can and does cause. It's not particularly lung based, but there's certainly evidence of psychological damage, particularly to young people. So that's, I've heard her give this talk already. I invited her after hearing her speak, and it's a very, very good talk, very thought-provoking, particularly for those of us who've got children, as vaping is so prevalent in school-age children. So if you have any interest in that, then please do tune in next week. Katie, thanks very much again. I'll see you all later. Enjoy the rest of your week and the weekend. Take care, everyone. Goodbye.